Hi, Bridget. Can you hear me?
Hi, Lariska. Yes, I can.
Great.
Do you want to have a go through your slides just to make sure that you're happy, or are you comfortable?
Should I share?
Just to make sure that you are comfortable, but I believe you've done this before, so
Let's just give it a go. So there I am sharing.
yes.
What are
Sorry.
you seeing though?
I'm still seeing your internet browser.
No, see, that's not I just want to make sure because I've got two screens and that now the technology is above me. And now, what do you see now?
Still seeing your Zoom meeting.
Let me just try this again. Okay, let's see now.
Ah, yes, there we go. I can see your presentation.
Okay, so I need to say screen two. Noted.
Okay, perfect.
Okay,
Lariska, I'm going to make you and Jacques co-hosts for the meeting, just in case anything funny happens to,
you.
yes, happens to the internet.
Sister Annie. I see Sister Annie, but we can't hear her.
I think she's got her mic off. Okay, great. So you're happy, and then I think we'll just wait for Jacques to come on, and then I'll make him a co-host as well. It sounded like he was happy to talk through the introductory slides.
Great.
And then so it sounded like he wanted to speak for about half an hour as well. I know you said you wanted to give about a 45-minute presentation, but in terms of time, are you going to be okay to?
I'm gonna rush it and see how quick we can get through it. I
Okay.
think 30 minutes is probably a bit tight, but I'll try and get through it by 35, 40.
Okay, no, that's
But
fine. I just mean
I'll
like,
set a little timer, and if my timer goes off, then then that's it.
yeah, it would just mean that there's a little bit less time for discussion. That's all.
Yeah. No, I'll try my best.
Sorry, yeah, sorry about that. I wasn't sure.
No, no.
Okay. All right, great. Thanks so much, Lariska. So nice to meet you virtually.
Yes. So, I'm sure Jog will come up shortly.
Sure. Hi, Jacques. It's Bridget.
Hi, Bridget. How are you?
I'm well, thanks. How are you?
I'm very good. Sorry, I'm still in time, so
No, you've got, yeah, you've got time.
I'm ready to share the slides. So I'll my slides and our introductory slides I'll handle from this side.
Okay, that's perfect. I'm going to make you co-host as well. I said to
Okay.
Lariska just in case anything funny happens with
Okay.
internet things. It shouldn't be a problem, but yeah. You
Okay.
never
No,
know.
that's perfect.
Okay, great. Thanks. Um, So then I think as usual, once it gets to 4 o'clock and we've got 30 to 40 people online, then you can go ahead and start whenever you're ready.
Okay, I'll do that. Thanks, Bridget.
Okay, great. Thanks so much, Shark. And yeah, really looking forward to it, both of you.
All right. Great.
Okay.
Good afternoon, everyone. Welcome to this afternoon's deep dive. Can I just confirm that I am loud and clear and that my screen is visible, or my screen is sharing?
Yes, it looks great.
All right. So this afternoon's session is going to be covering the topic of hereditary hemochromatosis and iron chelation. The speakers are myself and Dr. Haupt. Just some housekeeping. Some housekeeping notes is that the recordings may be found on the Blood SA website under resources deep dive, and you're welcome to answer to add any questions or comments in the chat box, and I'll get to that discussion time. Where you're also welcome to put up your hand and ask the questions in person, if you want to be added on the mailing list, you can email Melanie at melaniedavids@uct.ac.za. CPD points will be automatically submitted, you can contact Melanie Davids regarding questions about the CPD points, and 1 hour of attendance is required to qualify for the weekly CPD points. And remember to give the feedback on the speakers and the sessions. The feedback is anonymous, so you're welcome to speak your mind. we just want to again thank the deep dive management team, Prof. Berg, Gardine Kritzinger, and Melanie Davis. Thanks for the smooth running of this amazing program. So our agenda, as I said, is hereditary hemochromatosis. Dr. Larissa Haupt will start with that, and then I will give a talk on iron chelation. Next week's topic is redefining the CLL treatment pathway. Just to introduce our first speaker, Dr. Haupt is a hematologist at our lab here in Universitas Academic Hospital. She's involved in laboratory diagnostics and research, and is a UFS lecturer for undergraduate and postgraduate students. And she, as you'll see, she has a personal journey with hereditary hemochromatosis that has developed into a keen interest in the topic. So really looking forward to that talk. And I think everybody knows me. I'm not going to introduce myself, but yeah, I'll give the second talk on iron chelation. So let me just end the show there. Larissa, you can share your screen. Let me just stop my share. So you can share your screen and go ahead with your talk.
Sure. Right, can you see my slideshow?
Yes, we can.
And it's advancing. Jock, is it advancing?
It's advancing, Larissa, yes.
Okay.
Sorry, I
Great.
muted myself. Yes, it's advancing.
Okay. Good afternoon, and thank you for the introduction, Jock. So as he mentioned, we'll be spending some time on talking about hemochromatosis or iron matters this afternoon. And as he also said, I've got a keen interest, and it does by no way mean that I am an expert in the topic, but I have walked a bit of a journey with this, and I'd like to share that with you this afternoon. So here is just the QR code for the registrars in the audience that'd like to get the references and the notes. But we'll just briefly look at the background, the genetic variants that make up this disorder. We'll briefly jump through the pathophysiology, spend some time on the clinical management and presentation, and then I'd like to share my personal journey. Right, so in its most simplest form, hemochromatosis can be defined as a genetic disorder that gives rise to iron accumulation. And as depicted in this family tree or genetic tree, you'll see that in most cases it is an autosomal recessive disorder, and that we'll get to the variants in a minute. So defining this disorder has really come more than a century and started as early as 1865, when a very familiar physician, Dr. or probably Professor Trousseau, described what is considered the first case of hereditary hemochromatosis. And he described a patient with slate gray skin, later coined bronze diabetes. Patient had clinical diabetes, and also on autopsy had what they called pigmented fibrosis of the liver, and we can all now imagine what that pigment would have been. Von Recklinghausen in 1889 coined the term hemochromatosis due to this very dark color of the blood in these patients, and then probably considered the father of hemochromatosis is Sheldon, who in 1935 described the largest case series to date, 311 patients, and almost 60 odd years later is the first time that the HFE gene was discovered by Feder et al. And this was specifically the HFE gene, which we know now has got a lot of homogeneity with the HLA gene on chromosome 6. So there are quite a few variants. The most important ones to bear recognition of is 1A, 1B, and 1C. So 1A is by far the most common, and it is the C282Y HFE variant. It is transmitted in an autosomal recessive fashion. Type 1B, the H63D, and 1C, the S65C, are also inherited in an autosomal recessive fashion, and when they will usually become clinically relevant is when compounded with the most common C2A2Y variant. And although the clinical manifestations across the variants do differ, these common variants do differ slightly, it's not something that I think needs to be elucidated too much. Then there are also the rarer forms, like the type 2 or juvenile hemochromatosis, which is either a mutation in the hemojuvelin or the hepcidin gene. And these patients will be very difficult to miss as they present with early onset significant tissue iron overload. Type 3 is the transferrin 2 gene mutation, and type 4 is a ferroportin mutation that is also exceedingly rare. So despite these last three rare types, the type 1 hemochromatosis is very common. How common? So quoting this recent publication in Nature in 2022, with a prevalence of 1 in 227, it can be called the most common genetic disease in the USA. So despite this observation, many physicians consider hemochromatosis to be a rare disease and do not really associate it with life-threatening complications. And I hope that this afternoon my personal journey will highlight this fact. It's also been coined the Celtic gene, specifically the HFE mutation or the Celtic disease. And in Ireland, the prevalence is as high as 1 in 70 persons having homozygous C2A2Y disorder. And even though they have gone a long way to help with the recognition of the disease and also establishing an association, they still estimate that a somewhat of 20,000 Irish citizens still have undiagnosed C2A2Y hemochromatosis. So if it is such a clinically aggressive disorder, why are there so many people that are going undiagnosed? Well, that's just it. The penetrance of this disorder is highly variable. So I really like this table from a recent review in the American Journal of Family Physicians, where you can see if we start at the top, where patients have the genetic variant, and we are talking homozygous patients here, there is a large proportion of them that will never have symptoms or laboratory abnormalities. 75% will have biochemical abnormalities, but no clinical symptoms, and no laboratory abnormalities will be defined to only elevated transferrin saturation. 50% again will have biochemical evidence in both transferrin saturation and elevated ferritin, but still no clinical symptoms or clinical overload. 25% will have clinical symptoms like atralgia, skin discoloration, malaise, fatigue, and we'll get a bit more into this in a minute, and also then the corresponding lab evidence, but less than 10% will have the severe clinical consequences like diabetes, cirrhosis, and all the other after effects of long-standing tissue iron overload. We don't have a lot of time to get into the pathophysiology, so I'm going to summarize it very briefly, that as you can see, HFE is central to what we call the body iron sensing mechanism to control hepcidin expression. And these HFE mutations basically mean that the sensing is dislodged and hepcidin is not transcribed, and this very low hepcidin level leads to abnormal iron absorption through the intestinal villus cells. Other problem with this disorder, despite the penetrance being so variable and low, is the clinical presentation is not very specific. So these patients often complain of of constitutional symptoms like fatigue, mild abdominal pain, sometimes some stiffness in joints, and they can at later stages maybe present with some endocrine disturbances, but not really so that you would think it's not appropriate for age. And slightly more specific features would probably be the skin pigmentation as first described by Trousseau, and this is very importantly a very late feature. And then there is probably one clinical hallmark, and that is swelling or arthritis of the second and third metacarpal phalangeal joints, which is pretty specific to hemochromatosis. And often this is accompanied by radiological findings, as seen in this X-ray. So in summary of these signs and symptoms, which again is mostly non-specific, you can see that a lot of these symptoms and signs can be attributed to other disorders or are signs and symptoms that you see in your general physician practices quite often. I'm just going to highlight again the specific ones, is the arthralgias and probably the skin discoloration, but the rest of the symptom list is quite vast, and this is by no means complete. What about diagnosing these patients? Why are there still 20,000 undiagnosed Irish patients? And that I don't think there's really a good excuse for, because the diagnosis is actually pretty simple. So in a target population, so this is usually familial testing or somebody that you found has an incidental high ferritin and transferrin saturation, you would follow one of various published algorithms. But basically, if your ferritin is above the reference value for age and gender, you will go on to do an HFE phenotype, and depending on the phenotype, further diagnostic testing will ensue. I recognize that I am in a physician-based audience, so I'd also want to draw your attention to the up-to-date algorithm, which again shows a very similar trend where suspected hemochromatosis, whether with family history or clinical features, will lead to ferritin and transferrin saturation results. And depending on what you find there will lead to you doing the molecular mutation, or rather doing that later on in your workup. So what is a normal reference range for ferritin? So for females, that's considered more than 200, and for males, more than 300. And the Bloemfontein audience members will see that this has changed from my previous delivery of this talk, when this was actually quite lower, and this is in correspondence with recent guidance that came out, which I will quote later. So once you've diagnosed a patient with a genetic variant and corresponding biochemical evidence of iron overload, the next step would be to look for tissue iron deposition. And this can be quite vast and a very expensive exercise. But I would like to say the two most important things to investigate is the cardiac function, and this is ECG based and plus minus a heart sonar. And next would be the liver structure and function, and this can be as simple as just doing liver function testing or liver imaging, which we'll get to next. The endocrine and investigations would probably be led more on a symptom and screening laboratory test-based fashion, and I will leave that to the physicians in the audience. I am quite interested in the liver though, and most guidance will have a first step of doing liver function testing, so that's your basic LFTs. Liver ultrasound is not very sensitive to most of the pathology associated with hemochromatosis, but it will pick up an enlarged liver or a fatty liver, and would probably be able to diagnose end-stage cirrhosis.
Maybe there's other place that we always go to, no? Yeah.
Sorry,
I'll ask
if you
them.
mute yourself.
Hi, Colette, can you mute? Just put yourself on mute, please.
Right. So MRI is probably the most sensitive, non-invasive modality to our disposal, where we can also use the advantage of looking at the heart at the same time. Remind me just to mention something about heart cardiac iron at the end of my talk. But basically, there are two techniques depending on which you choose to use, but it's T2 star grading, and it is based on the relaxation time of the liver. Liver biopsy, although not frequently used anymore, would probably still be stated as the gold standard. And this is where the liver iron concentration is determined by atomic absorption spectrophotometry and is expressed as a milligram of iron per gram of dry weight in the liver. And I have asked our anatomical pathologist about this previously, and this is almost never done anymore. But there is a histological grading, which is much easier to do, and this is based on the Pearl stain, which is very similar to what we do to evaluate bone marrow iron. And you can see this very basic scoring system to depict this iron overload. What about the heart? So a lot of the end stage features of cardiac overload is arrhythmia associated. So an ECG and a stress ECG is probably very important in these patients and would be the baseline investigation. And 24-hour monitoring is also advised, or Holter ECG is advised by most guidelines. The MRI is again based on the shortening of the relaxation time, and less than 20 milliseconds correspond to mark iron overload and ECG changes. So this graph here is actually not for hemochromatosis, it's in thalassemia major and iron overload, but it just shows nicely how the left ventricular ejection fraction decreases as the T2 star milliseconds also decreases. So there's a nice correspondence there. Right, next up would be the management. So you've diagnosed your patient, you've investigated for organ involvement of iron overload, and now the next heading is what do you do now? So there's no evidence-based, robust, randomized controlled trials to dictate the management of hemochromatosis. We know now from retrospective studies that venous section or phlebotomy does significantly decrease morbidity and mortality. So thus, future, prospective randomized controlled trials are unlikely to be published very shortly, because we know that there's a significant benefit. So what would be the control arm? So for now, this is probably the best and only thing that we can do for these patients. So when would we institute a venesection program? So for patients with underlying genetic variants and biochemical evidence of iron overload should qualify for regular phlebotomy. And this is a ferritin above the reference value as stated in the up-to-date guidelines, more than 300 for men, more than 200 for females, and a transferrin saturation of 45%. I just want to say one or two words on the transferrin saturation. In my own personal journey and some of the patients that we've managed in the clinic, as well as a few private consults, I can say that the transferrin saturation is often much higher than this, and it's probably not a very sensitive lab marker to use, and I'll show that with some published data as well. So this is the new guideline that I was referring to, and that's the European Association of the Study of Liver, and this is very recent, 2023 September. And I had to cut off this flow diagram, so it's going to follow in the next slide. But this basically just outlines what we've discussed up until now, is if there is evidence of iron overload, whether biochemical or organ-based, you will start iron removal treatment. And now you need to decide whether that would be by phlebotomy, or if absolutely contraindicated or not tolerated, you would use chelation, which I'm going to leave to Jock in the next lecture. But if venesection is not contraindicated and is safe in this individual or tolerated, you will go on to do venesections. And per this guideline, they mention weekly or bi-weekly phlebotomy. You would check the hemoglobin regularly. So less than 11 would mark probably that you need to increase your period between venesections. And ferritin, you would only worry about probably monthly or after every 4 venesections. And then after you reach 200, you would probably monitor it after every 1 or 2 venesections. And your target ferritin is 50. So that's low. So we are supposed to quite aggressively venesect these patients. The maintenance phase is going to be very individualized based on the patient's iron absorption, and you would probably have to find your sweet spot with your patient with regular monitoring, and you would tolerate a level between 50 and 100. This is the 2017 British Journal of Haematology guideline, which is also a very nice reference. And here they also state that patients with genetic hemochromatosis with biochemical evidence of iron overload should undergo weekly venesections, and they actually recommend a much lower serum ferritin target. And during this phase, they say you monitor the HB weekly and the iron studies monthly. So to summarize this, I would say we can go with a weekly schedule of venesections, initially depending on the patient's tolerance, and to monitor the HB probably 1 to 2 weekly and the ferritin monthly as per the British guidelines. What I found very interesting when I started reading about phlebotomy and hemochromatosis is that you could actually calculate the amount of iron that you are therapeutically removing from your patient by calculating the number of bags removed. So assuming that one bag of blood, about 450 ml, contains 200 milligrams of iron, when the HB is around 13, the iron absorption, so that is what you take off of your patient, but the patient is also absorbing at a rate about 20 milligrams per week. Thus, a weekly venesection schedule would remove about 180 milligrams of iron a week. So how much storage iron do we have according to this technique? So in normal men who have about 750 milligram of storage iron, 4 weekly venesections, so that's a month of weekly venesections, would completely deplete their stores and they would reach that iron deficient bracket in their ferritin. For women, it's obviously much lower due to us menstruating and pregnancies, and probably 1 venesection in a female would be enough to render her iron deficient. So in hemochromatosis, the iron loading can be quite fast. So usually it's in excess of 5 grams. So that would mean 27 weekly venesections or about 6 months of venesections. So you can see that's about 7 times the normal iron in a healthy man. But it can be as high as 20 grams of iron overload once starting these venesection programs. So in a lot of cases, it can take up to 2 years to get these patients to a target ferritin of, let's say, less than 50. This is a very nice depiction of iron studies once you start a regular venesection program. So this study was done, I think, in Italy, quite a recent publication. What they did here is they recruited newly diagnosed patients with hemochromatosis. They instituted them if they qualified on a once weekly venesection program. They venesected them until their ferritin was below 100, and then they followed them up 8 weeks later, So you can see the hemoglobin here that went down during the venesection program, but recovered quite nicely to probably above baseline at the 8-week follow-up. I'm not even going to speak to serum iron because it's a very poor marker. The serum ferritin, you can see here, very high at diagnosis, and obviously it being the cutoff for them to end the venesection schedule. You can see here that it was below 100, and also at follow-up, the ferritin remained quite low. But look at the transferrin saturation, and that's why I'm not convinced that this is such a good marker to put any money on. Is you can see, especially in the C2A2Y, that's the green box, that the transferrin saturation is very high in these patients. And even when their ferritin was below the target with their venesection program, a lot of them still had high transferrin saturation levels. And look at the 8-week follow-up, this transferrin saturation shoots up again, even though we know that the ferritin at this stage is relatively well preserved at the target value. So probably because it is a calculated value and related to serum iron, probably not the best and most stable marker to use, and I haven't found it very useful. But besides phlebotomy, what other lifestyle advice can you give these patients? So avoidance of iron-rich food is controversial. The British don't really recommend that, although that newest guidance that came out do say that patients should probably avoid iron-rich food, avoid obviously iron supplements, and avoid even vitamin C, as stated in that guidance. The most important thing that you will counsel your patient on is alcohol intake, which should be limited or avoided completely. For the patients that struggle with this recommendation, you can try and convince them by saying that you only discourage it whilst excess iron is being removed. But for our patients that are in established liver disease or fibrosis, complete abstinence is advised. The other thing that you should counsel your patient on is their susceptibility to infections or serophilic organism infections. So they should avoid all raw seafood, especially shellfish. And some guidance documents even go as far as to say that they should not swim in the ocean if they've got open wounds. So remember to just inform your patient about that as well. Iron chelators, I'm going to leave up to Jock because I just want to spend the last few minutes talking about my own story. So in this photograph here is my father, and to his right is my brother, and that is hubby over there. So my dad, at this stage, 71, goes for an annual GP visit. He's an excellent patient. He gets his physical exam, prostate, PSA, ECG, the lot. And after he goes back for his blood test result discussion, he says to me, the doctor says my iron is somewhat high, but there's nothing to worry about. So this bothers me, and I ask my colleague at the private lab to share his results with me, and this is his results. As you can see here, transferrin saturation of 82% and a ferritin value of 1,087. So this was me. So I send him for a hemochromatosis PCR, which, no surprise, comes back as a homozygous C2A2Y variant. So now I start thinking whether he's got any clinical symptoms. I obviously go and read a bit. And as far as I can discern, he does say that he's more fatigued. He does have weight loss, which he's not happy with at all. And he's got non-specific back and hip pain. So my father used to be a rugby player and has loved sports for his whole life. So this fatigue and weight loss is severely debilitating to his quality of life, and he is not happy about this at all. So I send him back to the GP and ask for some further evaluations. My father at this stage is not living with me in Bloemfontein. He's in Newcastle. And his liver function test is normal. His liver ultrasound at that stage is normal. His fasting glucose is normal, and he also has a normal ECG. So the next step is I consider family screening. And just to quote what the guidance says here, is laboratory screening should include FBC, LFTs, serum ferritin, transferrin saturation, and HFE should be offered to family members after the diagnosis of HFE genetic hemochromatosis. And it should include parents, if available, siblings, partners, and children. So at this stage, we thought to start with the male family members, and my brother had a very interesting history. So my brother at this stage, let me just calculate this back, is about 31 years of age. He had a vague history when he was 19, when he went to the GP also with non-specific symptoms and was also diagnosed as having high iron. This GP did refer him to a physician. We were both students here at the UFS at that stage, and he was referred to a physician here in Bloemfontein. I went with him to this consultation, and I was a second-year medical student, and the message was, his iron is high, but it's not high enough to worry. And that was basically that. So this is my brother's iron studies at that stage, and you can see here that the ferritin is 2,908, transferrin saturation 89. So obviously we went on to do his HFE mutation as well, and no surprise, he too was homozygous for C282Y. So I went back to him, obviously a telephone consult, and besides joint pain that he has in his hands and feet from time to time, we initially just thought it was gout before this variant was diagnosed with him. But other than that, he is probably asymptomatic. But we did do his liver function testing, and you can see that he did have a slightly raised ALT and AST. So in 2022, he started to complain of hip pain, and he was diagnosed with avascular necrosis of his left hip, and he had to go for an MRI of his healthy hip to see whether there were early features as well. And at this, I kind of got on the bandwagon and asked whether they could also do an MRI of his liver. And this is the result. Sorry, it's a screenshot, so it's a little bit unclear. But you can see here that the T2 star of his liver was estimated at 19 milliseconds, and this corresponds with a massive iron overload of 126 micromoles per dry weight. So normal being less than 36. So now onto the management of these two family members. So my father, living in Newcastle at the time, I referred him for therapeutic venesections at Sandbus, and he had a very good experience there. And I'll say a few words on Sandbus's therapeutic venesection program in a minute. Just to show serially how his 2 weekly venesections went. So his iron studies in the blue is the ferritin, came down very nicely. His transferrin saturation, on the other hand, as I previously mentioned, jumped around quite a lot, and at the most recent and lowest ferritin value was still very high. For those in the audience that are freaked out by weekly venesection schedules, look at this HB. You can see that if anything, his HB has actually improved over the last few months of this, or last few years of regular venesections. So to come back to my calculation of iron overload, for my father that's undergone about 28 venesections at 180 milligrams of iron, so we've relieved him of 5 grams of iron, and as you can see by his ferritin level in the previous slide, he's not at target yet. So unfortunately, in October this year, my mother phoned me and said he's not himself. She's worried. Luckily, since they have moved to Bloemfontein and are living here in a retirement village. And I decided now, finally, I'm going to stop caring for his hemochromatosis and had him admitted with a colleague. During this admission, the scary complications of hemochromatosis became much clearer. So he was diagnosed with an atrial flutter at a rate of 46. He had dilated cardiomyopathy on his heart sonar with an ejection fraction of only 45%. He had MRI evidence of pituitary iron overload, and his liver MRI also showed, although not as impressive as my brother's liver iron overload, still abnormal liver iron deposition. How we managed my brother was a lot more complicated because he is a bit of a difficult patient. So we just made do with wherever we could venesect him. So this is in my own living room. This is at Sandbus. This is at his GP in the small town where he lived in the Free State. And since his diagnosis, he started to work in Mali. He is a exploration geologist. And when he moved to Mali to go work there for 6 weeks at a time, I nearly had a heart attack. But we bought these venesection bags through the pharmacy, and he travels with them. And then they've got a little clinic at their base of operations in Mali, and there is a doctor who has graciously agreed to help him with the venesections. So he still undergoes weekly venesections even when in Mali. This picture here is, like I said, anything went. So this is a friend of his father is a urologist. So sometimes even this friend of his father also did some venesections. And you can see here that probably there's a little bit more than 450 mils of blood in this bag. So I've taken some liberties when calculating Rayno's iron deficit over the last few years. So he's undergone about 45 venesections. So when done conservatively, that's about 8 grams of iron. When done on bags looking like this one, you could probably add to that and make it about 11 grams of iron. So his last measured ferritin, again, bad patient. His last measured ferritin was end of year last year was still over 2,000. So we are still very far away from target in him. I just want to say one or two words on Sandra's therapeutic venesection program. Like I said, we had a very good experience with using this service. My father just always asked, he feels so sad that they're throwing his blood away. Why won't they use his blood? And I then went on to ask them directly, and basically for those of you that will be making use of this in the future, Sandra's will use hemochromatosis blood if all other donor criteria is met. So obviously that goes without saying. And for my father, who now uses rivaroxaban, that will be unfortunately a lifelong exclusion as long as he uses it, obviously. And my brother, working in Mali, is living and working in a malaria endemic area, and that would also be an exclusion for him. But for your other patients, keep this in mind. When will they consider using it in terms of hemochromatosis? And this is when the venesection interval reaches 8 weeks or more. So basically, when the patients require less frequent venesections and have been sufficiently iron depleted. So for my brother and my father, these non-specific and in my father's case, more specific features of their hemochromatosis, what is the prognosis? So I'm just going to highlight a few. For the cardiomyopathy that my father has, resolution sometimes occurs. So we are going to hold on to that hope. And we have started a more aggressive venesection program on him once weekly. The hyperferritinemia often has resolution as also by the target. And some of the non-specific features like the fatigue, weakness, etc., will also improve in most patients. And the arthralgia that both of them complained of often also has some slight improvement. But until we reach our target ferritin for both my brother and my father, we like to joke that they are the Iron Men of the family. And as with most things in our family, we will just handle this with some humor. And that is all from my side.
Thank you, Larissa. That was a wonderful talk, and it always helps to see just a detailed personal journey, and I think it adds to the impact of the condition. And I think the thing that just really struck me was the fact that, you were second year, it was a while ago, was told by a specialist physician that nothing to worry about. And I think his ferritin was already quite high at that point. And also the challenge, I seem to remember that getting the general practitioners to actually do the venesection so regularly, just alluding to your comment on should you worry about doing weekly venesections, I do seem to remember that you struggled to actually get the general practitioners to do weekly or every 2 weeks venesection, actually refusing to. So there's a...
Yeah, you're 100% right, Jock. You helped me and consulted on my initial management of my father, and the GP was actually floored. He could not believe that we wanted to venesect him weekly, and he actually just blatantly said no. So we settled on the 2-weekly regimen through Sanbis, which he did sign off on. But yeah, I think that it just speaks to that first quote that I gave, that despite it being one of the most common genetic disorders, the know-how of how to treat and diagnose it is still very lacking.
Mm. And I mean, I remember as a fellow that the guidelines initially for asymptomatic patients were suggesting a higher cutoff. I seem to remember at one point 1,000 ferritin or 800, but I think you would agree that sort of the newer guidelines and evidence suggest that damage occurs much earlier, and we need to start venesections as soon as they have any evidence of iron overload.
Yeah, absolutely. As soon as that ferritin comes to above the reference value and you've got established genetic variant diagnosis, then your venesection programs should start.
Yeah, so it's much more aggressive than definitely I was taught as an internal medicine or registrar. So I think that's a very important message, and that lots of complications can be avoided. I see Andrew, before I go to my talk, I see Andrew asked a question on the chat. So some of the things that he struggles with in relation to hereditary hemochromatosis is that patients presenting with a typical hemochromatosis phenotype but negative genetics. I mean, obviously the one option is that it's one of the other mutations, the rarer mutations, but I mean, I do know that these days those mutations are available to test. But I think I have had the occasional patients where all genetic testing is negative, even the other mutations like ferroportin and so forth. So there may be other cases where we don't know what the underlying genetic lesions are. Obviously, I think with a raised ferritin, I mean, this goes without saying, and I'm pretty sure Andrew knows that, but more for the registrars and the younger members of the audience, that not all raised ferritins are iron overload. And then, the occurrence of dual pathology, so genetic and transfusional iron overload. Andrew, maybe what can I maybe ask just your sort of your thoughts on your second and third comment, the issues related there? Just maybe elaborate.
Yeah, so I mean the second one is, obviously we've seen quite a couple of patients where obviously you've got malignancies and etc., bone marrow failure syndromes and etc. Sometimes the iron is higher, and then I think one of those things is it's doing a test is not reflex. You're just kind of assuming, well, this is transfusional iron overload, but that's when a family history helps. But because that's not just important for the patient. I mean, yeah, you can give the patient. I'm sure you're going to talk about iron chelators, but the question is obviously testing families. So that's. I mean, I'm sure I'm missing a lot of them. Because we just in a busy clinic, you just don't have time to take the history. But just it's an important point that it's not one or the other. It can common genetics and
less common conditions can definitely co-occur. Yeah, absolutely. And the last one about the iron deficiency, again, probably patients presenting with iron deficiency from some other cause, but have a family history or
I keep on going on to one of my other things. Sorry, apologies. So, and the second one is really, the third one was really kind of that when to investigate, because we've got more than a couple of patients where we've got them down nicely, and now they're on a really quite a prolonged venesection program, and then now the iron keeps them dropping, and then at which point you say, this is iron deficiency, and do we need to do colonoscopes and et cetera, et cetera, et cetera, when again, the obvious thing is, you're like, oh, we're venesecting. This is expected, when it's maybe over exaggerated and you need to investigate.
Mm. I think that's an important message that, I mean, there may be other reasons for the iron deficiency once they're at that point that they've been venesected. Lariska, I don't know if you've got any comments on the sort of testing, the negative genetics.
My only comment is just on the C282Y, the clinical relevance of specifically that variant, whether a homozygous like in my family or a compound heterozygous. So there are some guidelines that would actually not even recommend regular follow-up of anything but a compound or a homozygous C282Y. So to maybe answer Andrew's question, I think when you have a patient with a hyperferritinemia with the absence of C282Y variants, I think your approach to this patient is probably completely different. And as also pointed out when I gave this lecture at internal medicine, the gastroenterologists have a completely different approach to hyperferritinemia, and I think that would probably be more appropriate. What is interesting about the ferritin between my brother and my father, obviously, 3 or 4 decades between them, is my brother's ferritin values are much higher, and they actually correspond quite well to his MRI findings as well. So just again to show that there are quite a few other compounding factors in this disease, which also dictates the penetrance in a family. So I found that quite interesting in my personal journey as well.
Thanks. I just see Vernon has got his hand up before I go to the chat box again. Vernon, you can go ahead.
Thanks, Jacques. I just want to first say thank you very much, Lariska, for great presentation. I happen to have a very similar family story, and I think you've really pointed out some very, very key points. Just from my personal experience and just a couple of comments. I think first, I think we should be aware of some of the misunderstandings amongst GPs out there. The one is that they think high ferritins are dangerous. Ferritin is not dangerous. It's only a marker. It's only in hyperferritinemia cataract syndrome where you've got only one of the ferritin chains being produced. The ferritins are typically 10,000 plus, where they develop cataracts. And beyond that, actually nothing. So it's not the ferritin, it's the non-transferrin bound iron that starts to increase when the transferrin saturation goes above 60 to 70%. So for me, a key indicator, as pointed out on that initial table, is there has to be a high transferrin sats above 45% with your ferritin. Otherwise, that ferritin comes from something else. The second thing is about Andrew's question about iron deficiency. It's just to remember in these patients, there is an increased risk of some cancers, colorectal cancer, breast cancer, the most important, but there are others as well. And of course, if they develop liver cirrhosis and varices, they can start self-venesecting by bleeding from there. Yeah, I thought, and maybe my last point, and Lariska, you've now read the literature very recently, and maybe you can comment on this. So some years back, a paper was published quite a while back where they suggested that about, I think in that paper, it was 13% of heterozygotes for C282Y actually were phenotypically like homozygotes, suggesting that there's probably an additional mutation that was not tested for. And that one has to carefully look at your heterozygotes as well. I see in the most recent papers that I've seen, they say that it's actually quite rare for the heterozygotes to present phenotypically like homozygotes. I don't know if you've got anything newer on that. Thank you.
Thanks, Provenant, for the question. No, I haven't read about a true heterozygous without a compounding variant of HFE, another variant of HFE. So I think for me, the only thing that I would like to emphasize there is, again, be very specific about what you request from your laboratory. So if you just write HFE mutation, they might just do your C2A2Y and not do your H63D and the other mutation. So I think it's very important to just say that you want a complete HFE variant panel so that you can diagnose or pick up these compound heterozygous patients as well, because they can also have clinically relevant iron overload.
Thanks, Lariska. I see I'm going to allow Zina to ask a question, then I'll go to the chat box before I go with my talk, just in the interest of time. Zina, you can go ahead.
Hi, everybody. So it's a bit interesting because I've seen about 3 young males recently, and the one that comes to mind particularly, he's about 35, but he has ferritins that sit at around 500 to 600, but he's extremely symptomatic. And we've venesected him, but it doesn't seem to work. And I was actually looking up some information, and it showed that recent guidelines say that they should be venesected to ferritins of less than 50. So I'm not sure if anybody else has come across that. And then the next thing I wanted to know is hemochromatosis is not recognized as a PMB. So I thought of getting iron chelation therapy, but obviously medical aids won't pay for that. So is there any way to get around that if anybody has any idea? Thank you.
So Zinat, I'll answer your ferritin target value. So yes, the guidance, some of them would recommend the target value of less than 50, but the British Journal of Hematology is actually lower at 20 to 30. So you actually want to get them into that deficient threshold, and then try and suss out how regular the venesections are to actually sustain them at that target level. So that is correct. Jock, I don't know if you can talk to the chelators and the PMB. I'm not.
Yeah, I'm not sure about the PMB thing. So I mean, I think the indication. Oh, I must maybe let me give my talk, and we'll come back to that question, Zinat, about chelating in the indication for chelation in hemochromatosis. So I just wanted to maybe the Martinez's comment. So we wanted to ask why GPs are not concerned with high ferritins. I mean, I think the comment that we do see a lot of high ferritins in our setting of HIV and lots of infections may, I mean, every second patient that we admit in state sector at our general medicine ward at Bellingham have a ferritin over 2,000, and you may get a bit numbed by high ferritins in that setting. So that may be part of it, but I do think there's a need for GPs to be cognizant. I mean, if a patient doesn't have an obvious inflammatory condition and is the right demographics, I think you must test for hemochromatosis. And just the last comment, I think Lariska answered that in a talk about it's not that Sandoz is reluctant to transfuse. The blood just needs to the patient just need to fulfill their normal donor criteria. Yeah, so with regard, Tomek is asking, with regards to blood donation, the high iron levels are an infection control risk. Tomek, you maybe just clarify a comment. I mean, is that?
No, I was just responding to Martina's question as to why we might not be eager to transfuse this blood. So one of the issues is that if a patient's got a very high ferritin level, that unit might be prone to bacterial contamination and growth.
And that's why you only start using that blood if they fulfill other criteria once they venesection, once they've been sort of their ferritins have been brought down to within reason. All right, let me go over to my talk. Just share my screen. All right. Is my screen projecting?
Yes.
Yes. Looks
All right.
good.
There's a little bit of overlap, and I'll try and skip things that Larissa already touched on in the interest of time. I'll get back to the image at the end. You can think for those, and think where that image is coming from. So just very briefly, just to remind us about the normal iron balance, and generally we absorb 1 to 2 milligrams of iron per day. A normal Western diet contains 10 to 20 milligrams of iron, so we only absorb about 10% of what we take in. About 3 milligrams of iron is circulating in the blood, bound to transferrin. 300 milligrams is used daily or used in erythropoiesis. About 1.8 grams is in the red cells, and the 600 milligrams in the reticular endothelial system, the macrophages. And just to note that about 90% of our daily iron, or more than 90% of our daily iron requirements, is met by the recirculation by the macrophages, phagocytosing senescent red cells. We all know that we don't have an active way of getting rid of excess iron, but you do lose a little bit of iron in sweat and shed skin cells, and from the gastrointestinal shedding of enterocytes and bleeding. And then women lose an extra 0.5 to 1 milligram on average per day. Obviously, it's focused around a certain period when they have their menses. But average over a month, it's 0.5 to 1 milligrams extra per day. About 500 generally in women, around 1 gram in men is stored in the liver, and then about 300 milligrams in other tissues. So a normal total body iron stores is between 3 and 4 grams. And as Larissa clearly stated, the hemochromatosis patients can have levels much higher than that. Causes of iron overload, it's either increased intake, so transfusional iron overload, the various inherited bone marrow failure syndromes, hemolytic anemias, myelodysplastic syndrome, and aplastic anemias, and so forth. Then the iron-loaded diet that we talk about, African iron overload, and there's some contention about this because it's thought that those that do develop iron overload in the setting of this traditional beer brewing in iron-rich pots must probably have some genetic propensity to absorb excess iron, and there's probably or possibly a genetic component to that as well. There's also the rare, I assume probably relatively rare instance where repeated heme infusions to treat acute intermittent porphyria can lead to iron overload. And then the increased absorption, the various hereditary hemochromatosis that Larissa discussed. And then we know about the effect of ineffective erythropoiesis that leads to the suppression of hepcidin via mainly erythroferrone. This is seen primarily in thalassemia, some sideroblastic anemia, and some of the other inherited anemias, and sometimes also in myelodysplastic syndrome, where in the absence of transfusion, the patients become iron overloaded. And then there's also evidence of true iron overload in the setting of chronic liver disease, especially alcoholic liver disease and other chronic liver disease, where there's that increased total body iron, and it's incompletely understood, and it's possibly related to reduced hepcidin production. The consequences of iron overload have been very clearly demonstrated, but I thought just maybe to note why does organ damage occur, and it's via reactive oxygen species, and as the iron burden increases, it surpasses the body's need, and the transferrin sats increase, And as Pravernan stated, that's the most important determinant of organ damage. And it's this non-transferrin bound iron. And non-transferrin bound iron starts to increase at around 35% transferrin saturation, but around 60 to 70% is where significant organ damage can occur. And this NTBI is taken up by cells that have active uptake mechanisms, such as the L-type calcium channel, and this is mainly in the liver, heart, and endocrine organs, and this probably explains why these organs are the main targets of damage. And the iron reacts with hydrogen peroxide in the cell and acts as a Fenton agent, catalyzing the Haber-Weiss reaction, leading to the formation of reactive oxygen species and tissue damage, inflammation, and fibrosis. And maybe just an interesting fact, this Fenton reagent was developed. It's a chemical reaction where you have a iron and hydrogen peroxide, and then that Haber-Weiss reaction is able to remove organic compounds from wastewater. So it's actually used in wastewater reclamation. It was first developed in or described in the 1890s by a guy called Fenton. So this has already been shown. Just to mention, I mean, obviously the main targets, hepatic and cardiac, and then the endocrine organs. The hyperpigmentation or bronze diabetes that Larissa mentioned usually only occurs if more than 20 grams of iron stores is reached, and it is quite a late presentation. And then I'm not going to go through all of it, but yeah, just remember about the risk of infections with sort of siderophilic organisms. Just an image, and I think these days we won't see this frequently, but the typical bronze diabetes, involvement of the second and third metacarpophalangeal joint being the earliest joints, but then later on other joints are also involved, and hopefully we shouldn't be seeing this in our clinics anymore if the GPs do their work correctly. So just briefly, a basic algorithm from UpToDate for evaluating suspected iron overload. So you'll obviously have typical findings suggestive of iron overload, so the history of any transfusion needs, high transfusion needs, or family history of hereditary hemochromatosis, beta thal without transfusions, the various clinical symptoms that Larissa discussed, and obviously laboratory values. So if if they're low or normal ferritin, then you don't need to continue looking for iron overload. But if you've got an elevated ferritin and this ties into what Vernon said, that if your transferrin SATs is over 45%, you're most likely dealing with iron overload, and you determine the cause, you determine if there's tissue level iron overload, and if this determines more than 2 to 3 milligram per gram dry weight tissue iron loading, especially in the liver, then iron overload is confirmed, and then you need to manage it. If the transferrin SAT is less than 45%, it's unlikely to be iron overload, and you need to look for other causes of the elevated ferritin that we all know of: malignancy, inflammatory conditions, HIV, diabetes, alcohol, and liver disease. So just focusing in on my main topic is iron chelation, and the indications for iron chelation is the transfusion-dependent anemias, obviously, and then the non-transfusional iron overload as seen in non-transfusion-dependent thalassemias, and then hereditary hemochromatosis that's unable to tolerate venesection. So this is if they have severe cardiac involvement, and Zinat, this maybe ties in with your comment. I think your patient on the medical aid that's not reaching targets, I think you probably have to show that because, I mean, patient should be able to tolerate, if you've got normal cardiac function, weekly venesections until you get to that point. So compliance with that. And I think the only way that you'll probably be able to convince the funders to pay for it is to show that he or she can't tolerate regular venesections. Just to note, the ferritin targets is a bit higher. I don't know exactly what the guidelines say, but if you do chelation in a hereditary hemochromatosis, you don't aim for those iron deficient, or you aim for higher targets. And then in acute iron toxicity, intensive IV chelation with desferoxamine are used. So those are the clinical scenarios where you would use chelation. And the goals of therapy is prevention of the obviously toxic iron burden and maintaining safe iron levels. And then this is before you have iron damage, and then rescue therapy to when all unsafe levels have already been reached, as shown in the Lariska's cases. And it's just to note that even temporary toxic levels probably cause irreversible damage. And this is why over the last 10 or so years, 15 years, the guidelines have become more strict, that we start them earlier and aim to go low. And if you have established iron overload, you need more aggressive approach and higher doses of or combination therapy. Just to note that, just in terms of we'll get to the cutoffs for thalassemia later on and so forth. It's also important to note that even at higher doses, chelation therapy cannot rapidly remove iron. And at only a small amount, because only a small amount of intracellular iron is available for chelation at any time. And the liver is, however, cleared more rapidly than the heart and other organs. But it can take up to 3 to 5 years with chelation therapy to get the ferritin below 1,000 if significant iron overload exists prior to starting. The iron chelators that's available is the oral chelators, deferasirox and deferiprone, and then the intravenous chelator, desferoxamine. And these molecules differ in their action and structure. Deferoxamine is a hexadentate molecule where one molecule of deferoxamine can bind one molecule of iron. Deferasirox is a tridentate molecule where you need 2 deferasirox molecules to bind one iron molecule. And then the bidentate deferiprone needs 3 molecules to bind one iron molecule. I found this table quite interesting, of the different chelators that's available and others that are not available, just to give one a bit of a broad view of chelation therapy in general. It comes from a relatively old review on the topic. Deferoxamine was the first one available, and it was marketed in the USA and Europe in 1968 by Novartis. But there's also other hexadentate molecules that has not reached clinical stages. Interestingly, for us involved in the treatment of malignant hematology, anthracycline, we know about anthracycline cardiotoxicity, and dexrazoxane is also an iron chelator, hexadentate iron chelator related to deferoxamine, and it's used as a cardioprotectant, and it's been in use in the US and Europe since 2004. The next molecule to become available is deferiprone, and it's not available everywhere, but it was marketed in India first, became available in the early 90s, and then later marketed in Europe. At this point, it wasn't available in the US, but it is now available in the US. I'm not aware of, I don't know if it's available in South Africa. There were also some other molecules that was used, but never came to market. And deferasirox is the latest molecule marketed in 2005 and 2006, also by Novartis. And there's, just to note, there's some iron chelators that's being looked at as and it's been used in phase 1 and 2 trials as anti-tumor agents. So an interesting field. So deferoxamine, or desferol, as I mentioned, has been in use since the late 1970s, and interestingly, is produced by Streptomyces pilosis. And I had a bit of going down the rabbit hole with the Streptomyces, and they're involved very prominent in medicine as the genera of bacteria that produces many useful molecules, and also some of our chemotherapeutic agents, such as the anthracyclines. Other species produce anthracyclines. So once the one molecule of deferoxamine binds the iron, it forms a ferroxamine complex, and that's virtually completely inert metabolically. And iron-free deferoxamine is internalized by the hepatic parenchymal cells, where they chelate iron, and this is excreted in the bile, so there's biliary excretion. It has been shown that it can remove iron directly from myocardial cells, and deferoxamine is localized to lysosomes in the cells, and this induces autophagy of cytosolic ferritin. And then this lysosomal degradation of cytosolic ferritin releases the iron, and that's then chelated by deferoxamine and cleared from the cell. So this is intracellular iron is then excreted in the bile, and then plasma iron is chelated with that's chelated by deferoxamine is eliminated predominantly by the kidneys. And due to its very short half-life of about 20 to 30 minutes, it's given by a continuous subcut or IV infusion. So the normal dosing is 40 to 60 milligram per kilogram in a small battery-driven pump. It's important to note that higher doses is associated with pulmonary hypertension and neurologic toxicity, and then one should not give more than 2.5 grams per dose to avoid visual and auditory loss. And this is where the ferritin level also comes in, or is very important, is that you must keep your daily ratio of milligram per kilogram to the current ferritin in micrograms per liter to less than 0.025. So that ratio should be less than 0.025 to avoid ototoxicity. It's usually given as a subcutaneous infusion over 8 to 12 hours, and it must be at least 5 days per week to be effective. And strict compliance to this should result in a loss of 600 to 1,500 milligrams of iron per month. And if you can keep the transfusion rate less than 4 units per month, then they can get a negative iron balance. You can use more intensive chelation regimens with persistent 24-hour infusions if they've got severe iron overload with cardiac arrhythmias and left ventricular dysfunction. Looking at the side effects, so acute side effects can be abdominal pain, diarrhea, nausea, vomiting, hypertension, and really anaphylaxis. Chronic, I've spoken about the visual and auditory neurotoxicity, and it's generally reversible upon discontinuation. Deferoxamine can act as especially the ferroxamine can act as a siderophore. And organisms such as mucormycosis, Yersinia, and the Vibrio filnificans, they do have an increased risk of infection when treated with deferoxamine. In terms of monitoring, so audiology is formal assessment should be done prior to initiation and then yearly, and then should be screened in the clinic every 6 months, and ophthalmology evaluation 6 monthly in children and annually in adults. Urine function should be monitored with a UNE and a urine protein creatinine ratio every 3 months, and discontinue if there's a more than 2 times upper limit of normal increase, and temporary hold if there's a 50% increase, and to reduce the dose if there's a 33 to 50% increase. You should also temporarily hold if the protein creatinine ratio is above 0.6 milligram per milligram. Liver function should be monitored every 3 months and held if the ALT is 5 times the upper limit of normal. I think that's unique to deferoxamine is that there is a risk, there is some concerns about growth velocity, and children should have ongoing measurement of their height and weight velocity, and if there's slowing of that, there should be specific management of it with growth factor. And so deferoxacirox is a synthetic chelator. It's well absorbed and has a long half-life, about 8 to 16 hours. Primarily, so it primarily have biliary excretion with very little renal excretion, and it's this deferoxacirox iron complexes. It's readily taken up by hepatocytes, but its action is different from deferoxamine, where it chelates cytosolic iron and then leads to proteasomal degradation of ferritin. So it's actually got a different intracellular mechanism of action, where deferoxamine add ferritin degradation via autophagy and the lysosome. With deferoxacirox, it's proteasomal degradation of ferritin after it chelates cytosolic iron. The 2 formulations on the market, both from Novartis, is Xjade, which is a dispersible tablet that's mixed in water or juice. And the dosing for transfusional iron overload is 20 milligram per kilogram, maximum 40, and the non-transfusion dependent thalassemia, a lower dose. And then there's the newer Jadena formulation, which is film-coated tablet. It's not dispersible, or granules that's sprinkled over soft food. It's got less GIT side effects than Xjade. And it also is better bioavailability, so it has a lower dose. The side effects of deferoxacirox differ a little bit from deferoxamine. Common gastrointestinal side effects is usually transient, 1 to 2 weeks, but can be significant. Skin rash and back pain is also relatively common, also self-limiting. But there is serious toxicity that one should monitor for, and there's been fatal cases of this reported: GIT hemorrhage, renal toxicity, renal failure, and Fanconi syndrome, hepatic toxicity and failure. There's uncommonly cytopenias leading that can be quite severe, and there's been leukocytoclastic vasculitis and hypersensitivity reactions reported. It's very important to note that the serious side effects are more common with advanced age and in the use of high-risk MDS, and if there's underlying renal and hepatic impairment. So in your elderly patients, they should be monitored very carefully for these side effects. So you'll see, compared to deferoxamine, the UNE and the renal monitoring is more intensive. It should be done monthly. Full blood count can be done at baseline and then monthly, and if the platelets is less than 50, it's contraindicated. That it's linked with that risk of gastrointestinal hemorrhage. And the liver function test initially every 2 weeks and then monthly. And the auditory and ophthalmic considerations is less of a consideration, but it should still be done at baseline and annually. Looking at the deferriprone, dose is 75 milligram per kilogram, and it's not a once daily dose, so it's 2 to 3 divided doses, and at maximum 100 milligram per kilogram per day. There is some data that is superior to deferoxamine for the treatment of established cardiac disease. So this may be a consideration where you've got prominent cardiac involvement, if available. The side effects is also prominent hepatic, raised in hepatic enzymes, also have some GIT discomfort. A unique side effect to deferriprone is arthralgia, and then there's a significant risk of neutropenia with 2.1 to 2.8% and agranulocytosis 0.2 to 0.4%. And there's been some fatal cases reported in the literature. And there's a potential problem which the clinical significance is not well known, but in cell cultures, the ferriprone potentiates oxidative DNA damage. And yeah, as mentioned, that this is the clinical significance is not known currently. The FBC monitoring is much more intensive for deferriprone. It should be done weekly for 6 months, and then every 2 weeks for 6 months, and then every 2 to 4 weeks after 1 year. And if the neutrophils drop below 1.5, it should be stopped, unless and not restart unless the benefit clearly outweighs the risk. And then patients should be aware of fever and to report if they have any fever. The liver functions is monitored monthly. If there's arthropathy, generally you can stop and restart once resolved and at a lower dose. Zinc deficiency is a rare complication, and mainly in those with diabetes. So you should monitor their zinc levels every 3 to 6 months and supplement if low. So there's no doubt that iron chelation made a big difference in the outcomes of thalassemia, transfusion-dependent thalassemia, and this is looking at cohorts, early cohorts where early cohorts where only 25% survive, but after the age of 10 years, so they die because of iron overload. And then as in this period deferoxamine became available, the proportion surviving past 10 years is much higher. So in chelation, the use of chelation in thalassemia should be initiated once more than 10 transfusions have been received, or if the ferritin is over 1,000, whichever comes first. If the MR liver concentration is more than 3 milligram per gram dry weight, or the cardiac T2 star is less than 20 milliseconds. And this is usually required at age of 2. In non-transfusion dependent thalassemia, the ferritin underestimates the degree of iron overload. So it's more difficult to use the ferritin as your guide. And MRI is preferred and should be initiated once it's 5 milligram per gram dry weight in non-transfusion dependent thalassemias. And if this is not available, generally once the ferritin is over 800. So the initial agent in thalassemia is generally deferoxamine is preferred, and it's mainly because of ease of use and compliance. Deferoxamine is a suitable alternative, but compliance can be problematic. And because of its potential toxicity, especially the neutropenia and the concerns around that, deferriprone is usually only used if the other two are not effective, tolerated, or unavailable. And there's no doubt that compliance directly affects outcomes, and full compliance is only seen in about 50 to 80% of patients, and survival to 30 is seen in approximately 55% of patients, and this compares to about 25% prior to availability of chelation. And that there's some data from Torino. So their data show that patients survive to 30 in 88% of cases if they are fully compliant, and that was 60% of patients and of their patients, and only 10% chance to survival to 30 if they're non-compliant to chelation. So it's critical that one addresses compliance in these patients. Only 40% of their patients were non-compliant to their chelation regimen. So how it's important that you monitor their iron load in transfusion-dependent thalassemia. You should calculate the rate of iron loading, where it's a calculation involves the number of milliliters or units transfused, and it will give you a value of how much iron they accumulate per day. And if that value is 0.3 to 0.5 milligram per kilogram per day, then they require average doses. If it's more than 0.5, you may have to increase the dose. If it's below 0.2, you may have to decrease the dose. And remembering about the ferritin dose ratio for deferoxamine. And then the ferritin levels is done at baseline and then every 3 months. The cardiac T2 star is usually done initially at age 8 to 10, but can be done earlier if significant degrees of iron overload or if the ferritin and liver iron concentrate worsens on therapy. And once it's done, it should be done every 2 years if the values are stable, if you've had a prior normal T2 star, but annually if there was significant iron overload present. And any time if that T2 star falls below 15 millisecond, and additional cardiac monitoring should be done. So in transfusion-dependent thalassemia, successful chelation is defined by ferritin less than 1,000. So this is completely different from the hemochromatosis. So it's important to note that. When the liver iron concentration is 3 to 7 milligram per gram, and the T2 star is more than 20. And you hold or reduce the dose if the ferritin is less than 300 to 500 and the liver iron content is less than 3. And you intensify the treatment, and you usually make a decision averaged over a period of 6 months based on your values, but a ferritin over 2,500, liver iron content over 15, T2 star less than 15, or any other organ dysfunction. And the options is to maximize the doses, switch to an alternative agent, or combine agents. Deferoxamine plus deferiprone has the most data, but you could also use other combinations. There's just less data for them, also depending on what is available. Iron chelation in non-transfusion dependent thalassemia, they have a slower development of iron overload, about 1 to 3.5 grams per year versus 2 to 12 grams in transfusion dependent. Interestingly, they deposit iron relatively more in hepatocytes versus macrophages. Thus, there's a lower increase in ferritin for the same liver hepatic load compared to transfusion-dependent thalassemia. And they develop iron overload complications by the age 10 to 15 compared to 2 to 3 years when transfusion-dependent. So you generally start monitoring non-transfusion-dependent thalassemias at age 10. For beta thal intermedia, hemoglobin H disease or alpha thal intermedia has a slower iron accumulation, so you can start monitoring them later around age 15. I'm almost done. I can see I'm reaching the end of our time. But in the myelodysplastic syndromes, the use of iron chelation, there's no standardized guidelines. And there's no strong data to show clinical benefit. There is the Chelation trial where they had 225 lower risk MDS patients who were treated with deferoxamine versus placebo, but the trial was closed early due to poor accrual, and the trial design and objective changes during the trial made conclusions problematic. But the deferoxamine group did show improved event-free survival, 3.9 years versus 3 years compared to placebo, and there was a trend to median overall survival advantage. So the general recommendations are to consider chelation in a lower risk MDS. So they should have an expected extended survival after 20 to 50 transfusions, or if there's MRI evidence of liver and cardiac overload. Other iron overload scenarios, so just a note on hematopoietic stem cell transplant. We know about the data that suggest iron overload is associated with worse outcomes. There's very little data on the benefit of chelation, but deferoxamine has been shown to be effective and tolerable in some small trials. So it is generally used where there's iron overload in this hematopoietic stem cell transplant, if they're getting a transplant for whatever receding condition that led to iron overload. In aplastic anemia, there's also limited data. It at least has been shown to be effective, and there was a decrease in ALT levels, but there's a significantly, this is now the use of deferoxamine, there was 25% of patients had a significant increase in creatinine, especially those who were using cyclosporin. Very briefly, a note on other agents. Vitamin C can mobilize and chelate iron, but it probably does so too quickly and can cause toxicity. So it's not recommended as part of a chelation program. And then calcium channel blockers, because iron use high capacity calcium channels to enter the cells, use of calcium channel blockers may limit tissue accumulation of iron. And there's some data to show improvement in cardiac iron loading, not in the liver. It's only been shown to affect the cardiac loading. But it's not routinely recommended due to potential side effects of hypertension and edema. So, in conclusion, iron chelation is a critical part of the management of various forms of iron overload. It's effective and safe if used, but the use requires close monitoring for efficacy and toxicity. And I think one shouldn't ignore the possibility of serious toxicity and monitor your patients correctly. Just again, the message that the patient understand and buy-in is critical. The patient understanding and buy-in is critical to successful outcomes. So that in the end you don't do like Magneto in X-Men, where he drew out the iron in the prison guard's body, and obviously it didn't survive it. So hopefully when we remove iron from our patients' bodies, they will have better outcomes. I see that we're a little bit over time. Apologize for that. I think we had a good discussion prior to my talk, but I just want to see if there's any burning questions. Just see here. Okay, so it seems like Janet says that the ferriprone is available under section 21. So that's good to know. In those where we struggle with the other two, generally it's used as an add-on or a additional therapy when others are not available or not effective, or obviously side effects. So the BJ. Caroline mentions the BDH guideline is to commence chelation in transfusion dependent after 10 to 20 transfusions, or when the serum ferritin is more than 1,000 on 2 occasions. I think, that was what I didn't mention, the 2 occasions, but that was what I was referring to. Vernon, you've got your hand up.
Thanks, Jacques, and thanks for a great overview. It's a very difficult topic if you have to cover so many different disease areas. So thanks for that. Just an interesting thing to note is the potential positive effect on hematological improvement with iron chelation in myelodysplastic syndrome, aplastic anemia, and myelofibrosis. And I just want to share one interesting case. So initially, XJADE was developed, worked very well, showed hematological improvement in a certain number of patients, but there were some problems with gastrointestinal side effects, and then the new formulation with JADE was developed. And one of my patients that I thought was quite interesting developed complete transfusion independence on XJADE. And where previously she needed about 3 to 4 units of red cells at least per month. Then she had some side effects that I was concerned was probably related, upper GI side effects from the XJADE, and I switched her to JADE, and she became transfusion dependent again. And then I switched her, after a couple of months, I switched her back to XJADE, and she became transfusion independent again, which is very interesting because both contain D-ferrocyrox. Don't know if anybody else has seen this. I've not seen this published yet, but it makes one wonder whether one of the excipients in the XJADE could be, potentially contributing to whatever effect. I can't imagine that it should, and whether something changes a little bit. I don't know what it is, but it's just, I don't know if anybody else has seen this. If they did, I'd love to hear from you.
I've not specifically seen it, but I'm aware of the sort of, there is some published data on potential hematological improvements. I've not personally, I don't have a lot of experience and a lot of patients on chelation, I've not seen it myself, but I have had problems with toxicity, especially renal toxicity in older patients where I've used it in MDS. And just something maybe as a comment for the fellows and those still studying is that also a case of mine with myelodysplastic syndrome and with a del(5q) that was heavily transfused previously before diagnosis and iron overloaded and was on deferrasirox and really struggled to tolerate it from a renal point of view. She had a complete response to lenalidomide once started, and actually was able to start a venesection program on her, which managed to control iron overload. So it may sound counterintuitive, but if they lose or if the underlying hematological condition is treated, you can move over to venesection. It's much safer generally. Zinat, you've got your hand up again.
Hi, just a comment. A few years ago, we had a patient who was, MDS aplastic between there, but he didn't respond to ATG, equine and rabbit, and he became completely transfusion dependent. And at what we thought was going to be the end stage of his life, we could use XJade, and it completely reversed everything. His counts recovered. He became transfusion independent. We actually were just seeing him 4 monthly, and now he doesn't even come back to us because he's completely cured. So I think that XJade does have significant benefits in patients like these.
Oh, that's amazing. And one wonders if it's, as Vernon mentioned, maybe some other part of the formulation, or if it's it makes sense to me that it's probably some direct toxic effect of the iron on bone marrow function that wouldn't explain Vernon's case with the two formulations of XJade having a different effect. But it's amazing if, it's a great outcome.
Yeah, it was.
All right, we are 7 minutes over time, and I again apologize for that. I see there's one question. Lariska, or a comment from Lariska. She mentioned that the guidelines suggest recommend PPIs as they reduce iron absorption significantly. So in hemochromatosis patients, that's an interesting one. I wasn't aware of that. Gideon asked, any comment on reticular endothelial system versus liver parenchymal iron loading? Heard an interesting postulate that mild MDS is worse regarding iron overload due to ineffective erythropoiesis and low hepcidin with parenchymal deposition versus iron overload due to transfusion in severe MDS and high hepcidin with reticular endothelial system iron overload. So there's there's definitely, depending on the cause of iron, the cause of iron overload lead to different patterns of iron loading. But it's interesting to note that the two mild versus severe MDS, so the sort of the mean that the milder MDS may have more organ damage, because I think the loading that's more parenchymal will be associated with more severe tissue damage, or at least that's what my understanding is. I don't know if there's any other comments on that comment by Gideon. All right, so I think that was a good session. Went a bit over time, but it's something I think for the fellows, it's something that do come up in the exams. And that's why I specifically decided to go into the pharmacology of the chelators, because especially for us in state, we don't frequently use it, or at least not in all centers. I know in some of the centers you've got much more experience with using agents such as deferrasirox, but in some other centers where we see this infrequently, especially thalassemias infrequently, we don't have a lot of experience with chelation, and I think it's important that any hematologist have a good understanding on the uses and the use and management of iron chelation. All right, I think we can end it there, and we'll see each other next week for a session on CLL. Remember to answer the feedback questions when you log off.